Singla. I practice at Sham Nursing Home and Art Center, Railway Road, Moga. Today we are going to talk about arthritis. And arthritis is broadly classified into two types: inflammatory and non-inflammatory arthritis. Inflammatory arthritis, in which there is inflammation around the knee joint. Basically, that's why we call it inflammatory arthritis. In non-inflammatory arthritis, it usually occurs with age and overactivity, like the knee arthritis. Then in the age group, broadly inflammatory, talking about arthritis, it is of two types: seropositive and seronegative arthritis. Seropositive arthritis, based on the lab parameters, we get certain positive values, we label it as seropositive arthritis. Then if we don't get laboratory parameters positive, based on the symptomatology, we label it as seronegative arthritis. Then broadly, females are more commonly affected than males for any type of arthritis, inflammatory as well as non-inflammatory. Based on the investigations, then there are certain investigations which we do to ascertain and label it as inflammatory arthritis, such as the RA factor, the anti-CCP antibodies, the ANA levels, the anti-neutrophilic antibodies level. Then there is an arthritis profile which we go through. The lab parameters such as ESR and quantitative CRP, they tell us about the activity of the arthritis, the specific current activity of the arthritis. Different investigations such as MRI can also help in diagnosing the arthritis. It will help to show some form of inflammation. Inflammation can occur around the synovium of the joint, or it can also occur around the where the ligaments or the tendon attach. That is basically known as enthesitis. Then arthritis can affect symmetrical as well as in asymmetrical fashion, meaning it can affect both the joints bilaterally, or it can even affect unilaterally. Then it can affect one joint or more than one joint. Like in hand, it can affect more than one finger, that is more than one joint. Broadly, inflammatory arthritis, if it occurs in hand, if it affects hand, it usually involves the metacarpophalangeal and the wrist joint. The non-inflammatory type of arthritis, it usually involves the major joints such as the knee joint or the hip joint. It can even involve the small interphalangeal joint of the fingers. Then about the role of the treatment. The treatment broadly consists of injectable and oral therapies. The injectable, we broadly classify them into the biologics that can decrease the activity of the arthritis for a long term. Then about the role of oral drugs. The oral drugs, then we classify them into broadly one category known as DMARDs, the disease modifying anti-rheumatoid drugs. Most commonly used DMARD is the antifoliar drug, which is the methotrexate, which is easy to give, weekly dosage therapy, and it is more compliant. Then other DMARDs also exist, such as the traditional chloroquine, hydroxychloroquine, the leflunomide, but they have more of the side effects than methotrexate, affecting the renal as well as the liver functions. There is a newer DMARD, that is tofacitinib. Previously, it used to be a patent and it was very costly drug. Now the cost factor has come down significantly. Many companies have started rolling out this drug. It's a very wonderful drug. It is a Janus kinase inhibitor. Its use is basically available in two forms: the 5 mg and the 10 mg. Even 11 mg extended release is available. The 5 mg dosage is morning, evening, and 11 mg is single dosage, that is in the morning. Tofacitinib is not primarily used as primary option. It is basically to be used as an adjunct to methotrexate. The primary drug still is methotrexate, which is safe and has less side effects. Tofacitinib needs to be administered with caution in patients suffering from comorbid conditions, even if having a history of tuberculosis. It can be pulmonary or it can be extrapulmonary tuberculosis, because usage of this drug can lead to a reactivation of the pre-existing disease in the patient. So it has to be used with caution. we have to get regular lab profiles such as liver function test, kidney function test, and monitor the patient on these drugs. Then about the part aspect that covers the non-pharmacological part, that is the activity, that is also very important. Much of the symptoms of stiffness or the joint pain can be relieved with the use of physiotherapy. The physiotherapy, it can be an active part of physiotherapy, that you do on your own, or it can be even the passive part that others can do it for you. In many patients, we can use adjuncts such as ultrasonic massage to give pain relief. Then the use of steroids. Steroids are used in a sort of bridge therapy. It's not to be used for continuous usage, even low dose steroids. It's used as a sort of bridge so that the active phase of the rheumatoid arthritis can be overcome with this steroid therapy that can go on for 10, 20, or 30 days depending on the symptoms. So as steroids have major side effects than even the DMARDs, the disease modifying drugs. So this was an important information I wanted to give you. Thank you.